This is another video brought to you by Mama and Daddy's Little Helper. This video will delve into cerebral palsy. What it is, briefly describe how it comes about, how it affects a child, the different classifications of cerebral palsy, which includes types based on muscles affected, such as diaplegia, hemiplegia, and quadriplegia. Also, classification based on location of brain injury, such as pyramidal cerebral palsy, aka spastic, and extrapyramidal cerebral palsy, characterized by low muscle tone with weak, uncoordinated muscles, and mixed cerebral palsy. This video will also give an overview of an assessment you as a parent can do at home with your infant to screen for cerebral palsy, and give a home exercise program to assist in treating your child right away. Early identification, screening, and therapeutic exercise for infants and kids with CP is so important due to the brain's still developing, malleable nature called neuroplasticity. At birth, an infant's brain is not fully developed. During the first and second year of life, the brain is still growing, changing, and forming new connections. Therefore, it is possible that other cells may take over the work of damaged cells. With stimulation and training, this is more likely to happen. Cerebral palsy, or CP, is an umbrella term for a group of disorders which are non-progressive, which means it won't get any worse than what your child is experiencing now. Cerebral palsy is the most common motor disability of childhood. About 1 in 323 children has been identified with CP, according to the estimates from the CDC's Autism and Developmental Disabilities Monitoring Network. This developmental disability affects movement and posture mainly, but can also affect speech, general responsiveness, and if severe enough, self-feeding. It is caused by a brain injury that occurred before birth, during birth, or during the first few years of life. Due to the injury, the brain is hindered, affecting the ability to control the muscles. The child's ability to balance, strength, coordination, and walking are all affected. You will notice a child with cerebral palsy walking with something called a scissoring gait. The child will have their thighs together and turn inward. They will be bent at the knee, and their ankles will look like they're constantly pushing on a gas pedal, leading them to walk on their tippy toes. During infantile development, it is also true that children with CP usually develop skills in the same sequence as other children, but they acquire them more slowly, and they may learn them in bits and pieces. A skill that babies typically learn within 1 month may take the child with CP 2 months to learn, and then another 8 months to master. The initial incomplete skill learning and then the following enormous time lag until full mastery of the skills are reasons why the motor development of children with CP appears so different. The causes of cerebral palsy includes, but are not limited to, bleeding in the brain, infections of the brain including meningitis and encephalitis, and sometimes cerebral palsy comes about from an unidentified source. The main problem with children with cerebral palsy is that they have abnormal muscle tone. What is muscle tone? I want you to think about rubber bands. Rubber bands have elastic properties similar to that of muscles. How easily they are stretched depend on how soft or hard they are. Muscles have low tone or high tone, which makes them easy or less easy to stretch. Children with CP have muscle tone that is outside normal variation. If tone is low, it is called being hypotonic and is stretched more easily. If the tone is high, then it is called spastic and the muscle feels hard and resists being stretched. Approximately 80% of those with CP have hypertonicity or high tone. 10 have hypotonicity or low tone, and 10 have mixed cerebral palsy. Regardless of the variation in tone, either hypotonic or hypertonic, this leads to muscle weakness. Another prevalent issue with CP is abnormal movement patterns. When we use our muscles, we typically do not make one single movement, but a sequence of movements. A child with cerebral palsy has difficulty sequencing movements. Take reaching out for a cup to grasp, for instance. Instead of straightening the elbow to reach, the elbow will bend. Instead of straightening the wrist will twist. Instead of opening the hand will make a fist. Exercises done by the child's therapist in the clinic and the exercises done by the parents at home are crucial to preventing complications such as joint contractures, which can make movements even more difficult. Joint contractures occur when a joint is not straightened for weeks or months. The ligaments around the joint that hold the joint together are affected. Some become shorter, some become longer, but either will limit the range of motion of the joint. So now both the short muscles and ligaments limit movement. Later in this video, I will demonstrate stretches and exercises for lengthening and strengthening children with cerebral palsy. Cerebral palsy also has a wide variety of presentations, ranging from mild motor disturbance to severe total body involvement. Classifying the types of cerebral palsy can be based on the muscles affected or the location of the brain injury. Hemiplegia. In hemiplegia, one side of the body is affected by cerebral palsy. The arm is usually more affected than the leg. Frequently, children with hemiplegia are able to compensate for the one-sided disability with their unaffected arm and leg. They may learn most skills almost as quickly as children without CP, until it is time to walk. Weakness, poor coordination, and spasticity of the affected leg may delay independent walking by a year or more. Depending on the severity of the hemiplegia, the children may have little or limited use of their affected hand. Diaplegia. Diaplegia means that the legs are mainly affected. Often parents do not suspect a problem until their baby is 7 to 9 months old and fails to sit. Typically, children with diaplegia gain the coordination and balance required for independent sitting more slowly and not as well as other infants. Standing and walking are affected most. Due to spastic, tight leg muscles, children with diaplegia tend to stand on their toes, turn their legs in, and push their knees together. Depending on the severity of cerebral palsy, some children with diaplegia will be able to walk short distances with a walker, while others may progress to walking independently indoors and then outdoors. Quadriplegia. This type of cerebral palsy affects the muscles in the child's whole body. The muscles of the trunk, arms, and legs do not work properly. Even the muscles of the face may be affected. This may cause feeding and speech problems in addition to gross and fine motor difficulties. Children with severe quadriplegia have difficulties with most activities of daily living. The dyskinetic cerebral palsies are athetoid and dystonic. Athetosis means the movements are slow and writhing. Dystonic means the movements are slow, rhythmic, and twisting. In the ataxic cerebral palsy type, the movements are unsteady, shaky, and lack coordination. The Hammersmith Infant Neurological Examination, or HINE, can assist in early detection, diagnosis, and prognosis of infants at risk of developing cerebral palsy. It can be used on infants aged between 2 months to 24 months of age. What's great about this assessment is that it has good inter-observer reliability for all levels of clinical experience. So even if you are a novice, you can get the same score as somebody who is very experienced in the clinic. It also has a very high predictive value. A HINE score of less than 57 out of 78, the global total score, at 3 months has a 96% predictive accuracy of cerebral palsy. Parents or clinicians will look at the child in various positions, and they'll score the child from 3 to 0. 3 means it's normal. A 0 doesn't necessarily mean the child has cerebral palsy. It just means that they are experiencing some atypical development. However, if the child's score is less than 57 out of 78, the total global score, you may want to contact early intervention services as soon as possible. Both this assessment and the contact number for the early intervention services for your state can be found in the description. And remember, just because your child has a score less than 57 doesn't necessarily mean that they have cerebral palsy. Item 1. Facial appearance. A score 3 is if the child smiles or reacts to stimuli by closing eyes and grimacing. A score of 1 is if the child closes his or her eyes but not tightly and have a poor facial expression. A score of a 0 is if the child is expressionless and does not react to stimuli. Item 2. Eye movements. A score of 3 is if it's normal conjugate eye movements. A score of 1 is if there's deviation of the eyes or abnormal movements intermittently, so it'll come and go. A score of 0 is if the deviation is continuous and there's also abnormal movements. Item 3. Visual response. Test ability to follow a black and white target. Score of 3. Follows the target in a complete arc. Score of 1. Follows target in an incomplete or asymmetrical arc. Score of 0. Does not follow the target. Item 4. Auditory response. Test the response to a rattle or a toy that makes noise. A score of 3 reacts to stimuli from both sides. A score of 1, the child has a doubtful reaction to stimuli or asymmetrical response. A score of 0, there is no response. Sucking, swallowing. Item 5. Score 3 is good suck and swallowing. Score 1 is poor suck and swallowing. A score of 0 is no sucking reflex and no swallowing. Item 6 is the assessment of posture. First, look at the head in sitting. A score of 3, the head is straight and in midline. A score of 1 is slightly to the side or backward or forward. A score of 0 is markedly to the side or forward or backward. Item 7. Look at the trunk in sitting. A score of 3 is if the child is sitting straight. A score of 1 is if he's slightly curved or bent to the side. A score of 0 is if the child is very rounded, rocketing back, bent sideways. Item 8. Look at the arms at rest. A score of 3, the arms are at neutral, central, straight, and just slightly bent. A score of 1, there's a slight internal rotation or external rotation, and there's dystonic posture that comes and goes. A score of 0, marked internal rotation or external rotation, dystonic posture, hemiplegic posture. Item 9. Hands. A score of 3 is if the hands are open. A score of 1 is if there's intermittent adducted thumb or fisting. A score of 0 is if there's persistent adducted thumb or fisting. Item 10. Legs and sitting. Able to sit with a straight back and legs straight or slightly bent. Long sitting. That's a score of a 3. Score of a 1. Sit with straight back but knees bent at 15 to 20 degrees. Internal rotation or external rotation at the hips. A score of a 0 is unable to sit straight unless knees markedly bent. Not able to long sit. Marked internal rotation or external rotation. Item 11. Feet while the child is laying down. A score of a 3 is if the feet are central and neutral position. Toes are straight midway between being bent and being straight. Item 11. A score of 1. Slight internal rotation or external rotation. The coming and going of the tendency to stand on their tiptoes, toes up, or curling under. Item 11. A score of 0 has marked internal rotation or external rotation at the ankle. This is persistent tendency to stand on tiptoes or toes up or curling under. Assessment of movements. For quantity, a score of 3 is if the movement looks normal. For quantity, if the movement looks excessive or sluggish, it's a score of a 1. And a score of a 0 is warranted if there is no movement. Quality of movement. In order to get a score of a 3, the child has to have free, alternating, and smooth movement. A score of a 1 is if the child has jerky, slight tremor of movements. And a score of a 0 is if the child is cramped, asynchronous, has extensor spasms, athetoid, ataxic, very tremulous, myoclonic spasm, or dystonic movement. Item 14. The scarf sign. Take the infant's hand and pull the arm across the chest until there is resistance. Note the position of the elbow in relation to the midline. A score of a 3 is if the elbow is slightly past the midline. A score of a 1 is if the elbow is markedly past the midline. And a score of a 0 is if the elbow can't reach the midline or it goes far past the midline. Item 15. Passive shoulder elevation. Lift the arm alongside the infant's head. No resistance at the shoulder and elbow. A score of a 3 is if there's resistance is overcomable. A score of a 2 is resistance is difficult to overcome. A score of a 1 is there is no resistance. And a score of a 0, the resistance is not overcomable. Item 16. Pronation and supination. Steady the upper arm while pronating and supinating the forearm, but make note of the resistance. Score 3. Full pronation and supination. No resistance. Score 1. Resistance to full pronation, supination. Overcomable. A score of a 0. Full pronation and supination. Not possible. Marked resistance. Item 17. Hip adductors. With both the infant's legs extended, abduct them as far as possible. The angle formed by the legs is noted. Score of 3. The range is 150 to 80 degrees. A score of 1. The range is greater than 170 degrees. A score of 0. The range is less than 80 degrees. Item 18. The popliteal angle. Keep the infant's bottom on the bed Bend both hips onto the abdomen and then extend or straighten the knees until there is resistance. Note the angle between the upper and lower leg. A score of a 3. The range is 150 degrees to 100 degrees. A score of a 2. The range is 150 degrees to 160 degrees. A score of a 0. The range is less than 80 degrees. Item 19. Ankle dorsiflexion. With the knee straight, bend the ankle. Note the angle between the foot and the leg. A score of a 3 is between 30 and 85 degrees. And a score of 0 is greater than 90, as if the foot is pushing on a gas pedal. Item 20. Pull to sit. Pull the infant to sit by the wrists. Support the head if necessary. Look at the pictures for score 3, for score 1, and for score 0. Item 21. Ventral suspension. Hold the infant horizontally around the trunk in ventral suspension. Note the position of the back, limbs, and head. Look at the pictures for score 3, score 1, and score 0. Item 22. Arm protection. Pull the infant by one arm from the position of them lying down. Steady the opposite hip and note the reaction of arm on the opposite side. Look at the pictures for score 3, score 1, and score 0. Item 23. Vertical suspension. Hold the infant under the armpit, making sure legs do not touch any surface. You may tickle the feet to stimulate kicking. Score 3 is him kicking symmetrically. Score 1 is kicks one leg or more, poor kicking. Score 0 is no kicking even if stimulated or scissoring. Item 24. Lateral tilting. Describe side up. Hold infant up vertically near to hips and tilt sideways towards the horizontal. Note the response of the trunk, spine, limbs, and head. Look at the pictures for score 3, score 2, score 1, and score 0. Item 25. Forward parachute. Hold the infant up vertically and quickly tilt forwards. Note the reaction, symmetry of arm responses. Score 3 is after 6 months, and score 1 is after 6 months. Item 26 is the reflexes for your bicep, your knee, and your ankle. A score of 3 is easily elicitable. A score of 2 is mildly brisk. A score of 1 is brisk. A score of 0 is clonus or absent. The last two sections of the HINE exam are not scored. You just simply have to note the asymmetries and the behavior. So, before I describe the stretches and strengthening exercises, there's a few motor learning tips that every parent should be aware of. True skill learning, which is what you want your child to be achieving, will only happen if your child also participates with problem solving. When your child wants to move, if there's a toy on the floor that she likes, gets only some help from you, and does as much as possible on her own, then she takes part in the problem-solving process and skill learning happens. Another tip is practice a skill until it is well learned. Only after a skill is well learned will your child always be able to do it. Also, a demonstration may help your child. You can recruit a sibling to model the exercises so they have a better understanding of what to expect. We are now ready to begin the therapeutic exercises, also known as the home exercise program. The first stretch is the seated arm stretch. Gently grasp the child's arm over the chest as far as it will go with ease. Now straighten the elbow fully, or as much as your therapist recommended. Hold the stretch for 30 seconds while you talk to your child. Change your hand position and hold his left hand with your right hand. Move the straight arm forward and then up as far as the therapist recommended, or until it touches your child's left ear. Move the straight arm forward and then out to the side as far as the therapist recommended. Now hold this stretch for 30 seconds, again, while you talk to your child. The next stretch is the butterfly stretch. You're going to sit behind your child, place your hands on top of their inner thighs, and apply a downward pressure. Hold this stretch for 30 seconds while you talk to your child. Repeat this 3 times. Remember, the stretches are supposed to be done every day for a total of 5 to 15 minutes. The next stretch is the seated hamstring stretch. You're going to have one leg bent back while the other is straight and forward. You're going to try to keep as straight as back as possible and bend forward at the waist. You're going to feel a stretch in the back of the leg. Hold this stretch 3 times for 30 seconds. The next exercise is a strengthening exercise called the gluteal bridge. You're going to have your child lie flat on their back, engage their core, drive through their heels, and raise up into hip extension. You're going to repeat this 3 times for 10 repetitions. I'm done. The next exercise is hip abduction with a TheraBand. You can either do this for reps or for time. For time, you can do it 3 times for 20 seconds. Bring right leg away from the left, and then the left back towards the right. You never want your legs to be right next to each other. The last strengthening exercise is for children with CP who have trouble standing or are wheelchair bound. You wrap the TheraBand right above your knees, separate your knees, hold for 3 seconds, and bring your knees back together. You can do this for 3 sets, 10 repetitions. And remember, all of the strengthening exercises should be done 4 times a week, or every other day. 3 sets for 10 repetitions, or as tolerated.